Hello, thank you for joining us as we talk about the updates to the AHA guidelines. My name is Ashish Panchal. I'm a volunteer for the American Heart Association and lead author of the adult section of the AHA guidelines. I'm also a professor of emergency medicine at The Ohio State University, a medical director for Delaware County EMS in Delaware, Ohio, and research and fellowship director for the National Registry. So today, we're going to talk about advancing cardiac arrest care through the 2020 AHA resuscitation guidelines. So these were a comprehensive set of guidelines which hopefully they will direct us to implement future benefits for all of our patients. So let's get into it. So we know cardiac arrest is a major problem. It's a leading cause of morbidity and mortality throughout the United States and even worldwide. When we talk about the United States alone, 350,000 adults and about 7,000 kids are affected with out-of-hospital cardiac arrest, whereas almost 300,000 adults are affected with in-hospital cardiac arrest. Now, when we look at these two different groups, one of the things which is a stark reality is there is a lot of variability on survival itself. So why is there so much variability in survival? And what we recognize is the variability may well be coming from the strength of the chain of survival in these different areas. So the chain of survival itself are the critical actions that are required in rapid succession to maximize the chance of survival from cardiac arrest. Now here's an image of the chain of survival. In this image, you see some of the classic things. You see activation of emergency response. You see high quality CPR, the use of early defibrillation, all the way to the point of recovery. And we're going to be talking a little bit more about recovery and why that's so important. Now let's talk a little bit about the guidelines themselves. The 2020 AHA guidelines provides a comprehensive review of evidence-based recommendations for resuscitation for the world. Now in 2015, there were 5-year updates which we transitioned to continuous evaluations and focused updates. And those focused updates were a great way for us to be able to start getting new data out. Now, though we were able to get all this data out, when there are significant changes to science, these are reviewed, and in that expedited manner, we're able to roll them out for everybody. But with this guideline, we are looking at a full refresh. So in this next image, what I'm showing you here is all the recommendations of the 2020 guidelines. And what you can see is the total number of recommendations which are refreshed is 491 new or updated recommendations, giving us a thorough, comprehensive evaluation of care from everything from adult basic and advanced life support all the way through to the systems of care. A pretty comprehensive look at care. Now, one of the other big changes is to enhance the implementation of the guidelines. So let's talk about that. Now, what this is in the form of a modular guideline format. And I want to talk about this a little bit because it's going to be a little different manner in which you're going to see the data. So in the 2020 guidelines, we organized into knowledge chunks, and these are grouped into discrete modules of information for specific topics and management issues. Now, this was all described by Levine et al. In Circulation, so many of the AHA guidelines are moving to this format. Now, the power of this format is that, number one, it makes the guidelines much more recommendation-centric, and number two, it limits the text. So you're not reading a full chapter, you're reading quick synopses, and you're really getting to the gut of what is important for you to know as a practitioner. So the primary goal then from this format is to facilitate dissemination and implementation of the life-saving interventions. So here's an example, and you're going to notice this is not a cardiac arrest example. This is mental health and neurodevelopmental issues. But the most important thing that I want to point out is on the left you see our classic class of recommendation and level of evidence for the specific recommendations, a short synopsis, and recommendation-specific text so you know exactly what information and literature each recommendation is based off of. Makes it a lot easier to read and a lot easier for us to access online. So let's take a minute now and think about and talk a little bit about more in detail about specific highlights of the 2020 AHA guidelines. So I want to address some general core concepts that you're going to see which are probably going to change so much of the span of our care. At the same point, I'm going to focus a little bit more on pre-hospital management. So the 6 different core areas that I'm going to focus on are on the screen right now for you. The first being reaffirming the core resuscitation concepts. The second, talking a little bit more about epinephrine. The third, focusing on specialized resuscitation scenarios that you may face. The fourth being optimizing post-ROSC care. The fifth being neuroprognostication. And last but not least, recovery as a link in the chain of survival. So let's get started. So one of the exciting concepts of really evaluating all the evidence that exists when it comes to resuscitation is really taking a second look at what we believe are the cores of resuscitation. The great part is we discovered that the fundamentals haven't changed. We reaffirmed the importance of bystander recognition, early high-quality CPR, and defibrillation of shockable rhythms. So we know that those cores still exist. You are still going to be pushing at a depth of at least 2 inches, and you're still going to be doing compressions from 100 to 120. And that is our definition of a lot of high-quality CPR. Now you're going to add to that your compression fraction, your leaning, and making sure you have great ventilations. Now, when you look at this next image, this is basic life support algorithm. And in this image, I've boxed out 2 major areas, just like we had discussed. You can see at the top, in this new algorithm, recognition is still highlighted at the front end, and CPR and defibrillation is still highlighted on the bottom of this algorithm. So the next area I want to address is epinephrine. Now, epinephrine has been one of those things that we joke about. We joke about the fact that epinephrine can be given to anything and bring it back to life. And we've looked at the data of epinephrine previously, and we've seen a lot of variability in the evidence to the point that one randomized controlled trial, which was underpowered, really didn't have enough people to show us an effect, but showed no effect. So a lot of us looked at that and said, well, epinephrine doesn't really work. Well, the good news is recently we have a large RCT that evaluated the use of epinephrine, and the key findings were that it increases survival. And this was particularly true for patients with non-shockable rhythms. The survival benefit significantly increased for those patients even more than just the shockable rhythms. However, one of the challenges in this paper is that overall survival was poor, and the impact of epinephrine on neurological outcome was questionable when the time of the drug is prolonged. In this study, the median time for getting epinephrine was almost 20 minutes. In a lot of our EMS agencies here in the US, we definitely give it a lot earlier than that. So one of the focuses of our recommendations was, number one, to reaffirm the use of epinephrine as a class 1 recommendation, and secondly, to recommend early use of epinephrine. Now in these images, I'm showing you algorithms for both adult and pediatric cardiac arrest. In the adult side, you can see circled in red, epinephrine used as soon as possible for asystolic and PEA arrest. So these are your non-shockable rhythms. And this is mirrored in the pediatric. And it's in line with how quickly you think about doing defibrillation for the shockable rhythm. So you can see how we've prioritized early use of epinephrine for those non-shockable rhythms. Now, I think one of the other big things that we all agree about is that when we resuscitate patients, I think we recognize that not all these resuscitations are identical, that some of them require specialized management so that we can actually optimize the patient's outcome. Now, in this guideline, we've actually presented you with a lot of special circumstances, but a couple I definitely want to highlight as an example include the algorithms for guidance for cardiac arrest in pregnancy, as well as opiate-associated cardiac arrest. So let's talk about those for a minute. Concerning the cardiac arrest in pregnancy, the new algorithm that features this highlights a couple of very important concepts. The first one it highlights is team planning for maternal arrest. When you have a patient who has a cardiac arrest in pregnancy, you don't want to think about what the next step is. You don't want to think about where you're going to take this patient or having to pull this team together. A lot of that decision making and planning needs to be done beforehand so that you know that the place is ready for this patient. Now, the other aspect of this is that we highlighted in the guidelines the importance of lateral uterine displacement as well as perimortem delivery. To think about the second one, perimortem delivery, you most assuredly need a team which is ready and able to do this and resuscitate the patient to their utmost. Let's switch gears a little bit and talk a little bit more about opiate-associated cardiac arrest. Now, I think all of us have experienced the large burden of disease of the opiate epidemic. And associated with that, we have a large burden of disease of deaths who are people who actually have cardiac arrest because of opiates. Now, with this in mind, when we went through the guideline development, we went ahead and did an in-depth evaluation of all the literature associated with opiate-associated cardiac arrest. In these guidelines, we present 2 new algorithms which leverage the evidence evaluation of a new scientific statement on opiate-associated cardiac arrest. Now here I'm going to show you only one algorithm, which is the lay responder algorithm, but what it features is 2 key aspects. The first, for cardiac arrest patients, the mainstay of care remains the initiation of the emergency response system as well as performance of high-quality CPR. Now, for those patients who are in respiratory distress and failure, the goal again is to prevent deterioration and to provide naloxone. So those key aspects of the use of naloxone and of CPR are still held in these algorithms. Now, one of the areas that comes up, and we talk about it a lot, is what do we do for refractory shockable rhythms? And one of the concepts that has been out there, and I've also published in this area, is the use of double sequential defibrillation. Now, this is a tough area to talk about because for the patients with refractory VF, we don't really have very many options. Now, in some places you can take them for ECMO, which is an amazing intervention that you can do, but a lot of places aren't set up to do that. So DSD is one option where if you don't have the setup, maybe this is an option. Well, a large systematic review conducted by ILCOR looked at the concept of double sequential defibrillation and found that with the current data which is out there, they recommend against routine use of DSD. Now, there's a caveat to this. A recent RCT is currently being done, and some of the data is already out on it, which is evaluating double sequential defibrillation and alternative pad placement. So looking at those 2 concepts, we may have a better answer in the near future on whether we should be thinking about double sequential defibrillation or should we just be considering alternating our pad placement to help the best outcome for the patient. Now, in the end, what we have is we have a lot of unanswered questions in the pre-hospital space about DSD. This includes everything from shockable to intershock timing, pad positioning, technique, and even possibly the harm from increased energy. We don't have all the answers. We need to look a little bit more into this. Now, one of the great things about all the work that we're doing to optimize cardiac arrest is the very fact that we're having more survivors. This should be a part of our mantra now, is that cardiac arrest does lead to survivors and we need to be ready to optimize post-arrest care. So for all patients, no matter the cause of arrest, we know our overall goal is to optimize functional survival. And these guidelines, we feature the critical need to optimize post-ROSC care and to ensure these functional outcomes. And in both the adult and pediatric sections, we actually give you new guidance for this chain of survival. In this next image, what I'm showing you is on one side, the adult post-ROSC care algorithm and the peds on the right. Now on the adult side, you can see 2 major pieces here. You have the initial stabilization phase as well as the continued management and emergent interventions phase. Now, obviously in the emergent interventions phase, a lot of what we're talking about now is using targeted temperature management, doing EEGs, thinking about early brain CTs, and even thinking about other critical care interventions like PCI to get their vasculature open. Now, for you and I in the pre-hospital space, in this next image, I'm showing you what we would do specifically in the initial stabilization phase. After ROSC is obtained, one of the most critical things that we need to start thinking about is, of course, making sure the airway is appropriately managed, and that may well be an endotracheal tube. Second, we need to talk about our respiratory parameters and making sure that we're doing a good job managing the saturations of the patient and the PaCO2. And last but not least, managing the hemodynamic parameters. We recognize that many of these patients are going to have post-resuscitative myocardial dysfunction, and they may well require pressors to be at the benchmarks that we want. Now, when all is said and done, we want to, of course, do no harm. So if you're in the field and you have a patient who has been resuscitated and has a great supraglottic airway in, which is working, get them to the nearest hospital and let them change out that endotracheal tube. So we have to still balance everything we need to do towards the benefit of the patient and the benefit of the long-term functional outcome for the patient. Last but not least, on this same figure, I do want to point out is at the bottom we have obtain a 12-lead EKG. that may be critically important for us when we start thinking about our transfer decisions to different hospitals in our systems. So with that in mind, let's talk a little bit about PCI after ROSC. Now, we understand that the use of PCI in cardiac arrest is critical for our decision making for EMS transport. And within these guidelines, we provide new strong recommendations about what to do for PCI. So PCI after ROSC is strongly recommended for anyone who has a STEMI on their 12-lead EKG. Now, the more interesting piece here is that it is also reasonable for anyone who is unstable or that you have a suspected cardiac etiology to also be taken for PCI. So that means that if you have that patient who you looked at their EKG and their initial EKG may have been VF and they decompensated into a non-shockable rhythm, and then you resuscitate them, you get ROSC, and you're deciding to take them to the patient, because they started at that VF, you may be thinking that this unstable patient that I have may be a good candidate for PCI. Do what you need to do, take them by your protocols to the right place of care, so hopefully they can get PCI. Now, two areas that are not so focused towards the pre-hospital space, but I think are critically important for us to understand are neuroprognostication and recovery. And I want to start with neuroprognostication because this is a key aspect of when we think of post-ROSC care. Accurate neuroprognostication is important to avoid inappropriate withdrawal of life-sustaining treatments. And in the end, we may otherwise be taking away patients who may have a meaningful neurological recovery. A key aspect of this decision-making needs to be a multimodal approach to neuroprognostication. So in this guideline, we provide a new schematic which incorporates imaging, electrophysiology, clinical exam, as well as biomarkers. So here's the schematic itself, and one of the key facets of this is the decision-making that has to happen at 72 hours using a multimodal approach with using all of these different areas to prognosticate survival. So when we start talking to our hospital systems, when people are taken off of life support, one of the questions we should think about is how are they going about neuroprognostications? Ask the question, because that could well mean the difference between survival and not. Last but not least, I think all of us have worked so diligently and it's worked so hard to improve outcomes for our patients and to improve how we do resuscitation. It's now time for us to focus on the care of our survivors, because survivors are a real thing. It's no longer what we were feared before, that if somebody has a cardiac arrest event, it's over. We have survivors and we know these survivors need care. In this guideline, we leverage a new scientific statement directed at survivorship, and we recognize that recovery is real and requires organized planning to optimize a patient's outcome as well as their transition home. We highlight this importance of this concept by having a critical new link in the chain of survival. And this is the link of recovery. And of course, since we know that recovery itself is a road, the road to recovery follows many steps. And this is going to be everywhere from the ultra short term to the long term. And even as pre-hospital providers, we can be part of this road to recovery, because we can be emotionally invested and emotionally involved with these patients, and really being able to close the loop about the people who helped rescue and really get the joy out of that experience with the patient. Now, keep in mind, when we make these recovery plans, they have to help guide patients, caregivers, even primary providers, and they're generally a great summary of the inpatient course as well as recommendations for the next steps. Because as they get discharged home, we have to have clear expectations of what their recovery expectations should be. Now, the 2020 AHA guidelines provide a comprehensive review of all the evidence for resuscitation and emergency cardiovascular care. In this discussion, I've only touched on a small amount of the improvements in resuscitation care. We've looked at research, practice, and even education. Now, through this evidence-based guideline process, we're able to drive dissemination and implementation of clinical practice. But in the end, our whole focus is one basic thing. The better we look at our practice, the better we look at our system, and the better we focus on implementation of these best practices, we know we're going to produce functional survivors. And that's our goal. Thank you so much for joining me today. It's been a pleasure talking about these updates. If you have more questions and more comments, definitely send out an email or send out a link. Thanks again.